Hey everyone, welcome back. Today we're going to talk about edema and we will focus on these 6 points mainly. When it comes to our first point or the definition, the word edema comes from the Greek word edema, which means swelling, and it's a presence of increased fluid in the interstitial tissue space or an accumulation of fluid in the body cavity in excessive amount. Depending on the site, fluid accumulation in body cavity can be variously designated as hydrothorax, which is fluid accumulation in pleural cavity in pathologic amount, hydropericardium, which is pathologic amount of fluid accumulation in the pericardial cavity, hydroperitonium or ascites, which is fluid accumulation in peritoneal cavity, and anasarca, which is severe and generalized edema of the body with profound subcutaneous swelling. And anasarca is associated with three organs, which is liver in liver failure, heart in cardiac failure, and renal in kidney failure. And we will talk about this later in the video. When it comes to the mechanism of edema formation, as you can see in the picture, around 60% of our body is made from water, and 2/3 of this water is located inside the cell, which is what we call intracellular fluid. And the rest 1/3 is outside the cell or extracellular fluid, and it's this extracellular fluid divided into plasma, which is around 5% of total body water, and interstitial fluid, which is around 15% of total body water, by semi-permeable capillary endothelium. And the capillary endothelium is highly permeable to water and almost all solute in plasma, with the exception of protein. Protein, the plasma, and interstitial fluid are especially important in controlling plasma and interstitial fluid volume and exchanges among them. Normally, any outflow of fluid into the interstitium from the arterial end is nearly balanced by the inflow at the venular end. Therefore, there is very little fluid in the interstitium. Edema formation is determined by 5 factors, which are hydrostatic pressure, oncotic pressure, vascular permeability, lymphatic channel blockage, and sodium and water retention. And we will discuss the first and the second factors together, since they are kind of interrelated. The passage of fluid across the wall of small blood vessel is determined by the balance between hydrostatic and oncotic pressure, and there are 4 primary forces that determine fluid movement across the capillary membrane, and each of them can be listed under these 2 basic categories, which are hydrostatic pressure and oncotic pressure. There are 4 primary forces, and these 4 primary forces are known as Stirling forces, and they are capillary hydrostatic pressure, interstitial fluid hydrostatic pressure, plasma oncotic pressure, and interstitial fluid oncotic pressure. The capillary hydrostatic pressure and the interstitial fluid oncotic pressure force fluid outward from the intravascular space into the interstitium, while the interstitial fluid hydrostatic pressure and plasma oncotic pressure tends to force fluid from interstitial space into the intravascular space. And this oncotic pressure are caused by the presence of plasma proteins. And normally the fluid extravasated from the vessel is higher than the fluid that return into vessels. So some proteinaceous fluid is normally drained by lymphatic channels, and usually excess fluid will accumulate in the interstitium, or edema is formed when the capillary hydrostatic pressure is increased, or when the plasma oncotic pressure is decreased, or when the lymphatic drainage is blocked. Here we see in the normal fluid exchange, the fluid will extravasate in the arteriolar side since the pressure is higher, return in the venular end as the pressure decreases, and some of the remaining fluid will drain through lymph. And when the plasma oncotic pressure decreases, the force that traps water inside the vessel decreases, so more and more fluid will extravasate and causes edema. And when there is increased capillary hydrostatic pressure, there will be increased extravasation, which also lead to edema. And when there is lymphatic obstruction, the extra fluid that should have been drained by lymphatic system will be accumulated and again lead to edema. And when there is increased capillary permeability, due to endothelial injury or inflammation, there will be increased extravasation. Basically, we can classify pathologic edema into two broad categories, which is edema due to decreased plasma oncotic pressure and edema due to increased vascular hydrostatic pressure. When we see the edema due to decreased plasma oncotic pressure, it happens in various diseases such as protein-losing glomerulonephritis or nephrotic syndrome, which leads to increased excretion. It also occurs in liver cirrhosis, which leads to decreased protein synthesis by damaged liver. It also happens in malnutrition, since there is decreased intake of protein, and protein-losing enteropathy, since there is decreased absorption. And when the edema results from increased capillary hydrostatic pressure, it happens in following diseases such as DVT or deep vein thrombosis, which results in impaired venous return, pulmonary edema due to left ventricular failure, and this causes blood to build up behind the failed heart, which is the lungs, leading to increased plasma hydrostatic pressure in the pulmonary vessels. There is also cerebral edema in trauma and inflammation, and there is also congestive heart failure. And there are mainly three mechanisms that lead to increased capillary hydrostatic pressure. The first one is reduced cardiac output causes hypovolemia and activate RAS or renin, angiotensin, aldosterone system, which leads to sodium and water retention. We will talk about this later. The second mechanism is back pressure hypothesis, which means the backing up of blood behind the failing heart will elevate the central venous pressure or pressure in the vein. And the third mechanism is the forward pressure hypothesis, which is chronic hypoxia may injure the capillary wall and cause increased capillary permeability and result in edema. And the fifth one is portal hypertension in cirrhosis, which produces ascites. Earlier we said in cirrhosis edema will occur due to decreased protein synthesis, but it might also occur due to increased portal hypertension, which in turn into peritoneal cavity and causing ascites. There are also another type of edema called myxedema, which is seen in hypo and hyperthyroidism, and it's associated with increased production of glycosaminoglycan. T-cell cytokines stimulate the fibroblasts to synthesize excessive amount of hyaluronic acid, leading to myxedema. When it comes to the clinical classification of edema, we can also classify edema into localized and generalized type. In the localized type, we find edema of brain first. Edema of brain or cerebral edema might be localized in the site of lesion, like neoplasm or trauma, or it might be generalized in encephalitis, hypertensive crisis, and so on. And we will see narrowed sulci and distended gyri in cerebral edema. And increased edema leads to a compression of medulla towards foramen magnum, leading to compression of vital center and herniation of brain, and the patient will die. There are three types of herniation: subphalangeal, transtentorial, and tonsillar herniation, but we will talk about them in another video. As you can see in the picture, in the normal sized brain, you can see the cell size clearly, but when we see the edematous one, the cell size are almost overlapping and the gyri are extended and flattened. The second type of localized edema is pulmonary edema. Pulmonary edema usually occur in left ventricular failure, or but it might also occur in adult respiratory distress syndrome or ARDS, and it might increase from 2 to 3 times of its weight, and it become fluid filled and have somewhat like liver-like appearance. The second classification is generalized edema or anasarca, and it occurs due to either reduction of albumin or oncotic plasma protein or increased blood volume. When it comes to reduction of albumin, it might occur due to excessive loss or reduced synthesis as caused by nephrotic syndrome, liver cirrhosis, malnutrition, and protein losing enteropathy. But it might also occur in increasing volume of blood secondary to sodium retention caused by congestive heart failure. When it comes to the third factor, we find vascular permeability. Increased vascular permeability usually occur due to acute inflammation. In inflammation, chemical mediators are produced, and some of these mediators causes increased vascular permeability, which leads to loss of fluid and high molecular weight plasma proteins into the interstitial, and such edema is called inflammatory edema or exudates. And we differ inflammatory edema from non-inflammatory edema by inflammatory edema occur due to inflammatory induced increased permeability and leakage of plasma protein, so it will be a protein rich exudate, while the non-inflammatory edema occurs in hemodynamic deregimentals like increased plasma hydrostatic pressure, decreased plasma oncotic pressure, and so on. So it will be a protein poor transudate. The other factor is lymphatic channels. Normally, lymphatic system returns a small amount of proteinous fluid into the circulation. Therefore, obstruction of lymphatic channel due to various causes leads to accumulation of this fluid. Such kind of edema is called lymphatic edema or lymphedema. Lymphedema occur in various settings. For example, parasitic infection like filariasis, which is caused by Wucheria bancrofti, and this causes massive lymphatic and inguinal fibrosis. Or it might also occur in lymphatic obstruction secondary to neoplastic infiltration, like breast cancer. As you know, breast cancer, around 75% of it's metastasized into axillary lymph node, so it might also occur in this setting. Or it might also occur in post-surgical and post-irradiation therapy, such as surgical resection of lymphatic channels or scarring after irradiation. And the other one is hereditary lymphedema. And since lymphatic system normally drain proteinous fluid, its blockage causes non-pitting edema. When it comes to the fifth factor, we find sodium and water retention. Sodium and water retention occur in various clinical conditions such as congestive heart failure and renal failure. And in this condition, the retained sodium and water results in increased capillary hydrostatic pressure, and it can occur either in primary or secondary phenomena. In the primary sodium retention, it's associated with renal disorder like nephritic syndrome. As you know, nephritic syndrome decreases GFR or glomerular filtration rate, which is perceived by our body as hypovolemia. So our body tries to compensate that by increasing water and sodium retention by activation of renin-angiotensin-aldosterone system or RAS. And the secondary sodium retention occurring such as congestive heart failure. In congestive heart failure, there are actually three mechanisms of water retention. There is intrinsic renal, there is extrarenal hormonal, and ADH or antidiuretic hormone mechanism. In the intrinsic renal, the hypovolemia caused by the CHF activates the baroreceptor and increases sympathetic outflow, which leads to renal ischemia and decreased GFR, and this will decrease also the sodium excretion. And in the extrarenal hormonal mechanism, decreased cardiac output results in decreased renal blood flow, which activates renin-angiotensin-aldosterone system with the resultant retention of sodium and water. And in the ADH mechanism or antidiuretic hormone mechanism, the hypovolemia increases ADH production, which causes water retention, along with many other factors. When it comes to the morphology, Edema is easily recognized grossly, but when you see microscopically, it's seen as clearing and separation of the extracellular matrix with cell swelling, and any organ or tissue can be involved. But edema is more commonly seen in subcutaneous tissue, lung, and brain. When it comes to the subcutaneous edema, it can be diffused or it might be more localized in a region with high hydrostatic pressure, and its distribution is often influenced by gravity. For example, it appears in leg when we are standing, and it happens in the sacrum and the genital region where we are lying down. And this feature is known as dependent edema. And this type of edema also causes spitting edema, which is when we press over markedly edematous subcutaneous tissue, displaces the interstitial fluid and leave depression, our thumb sign or our finger sign. Edema results from renal dysfunction, often appear initially in parts of the body containing loose connective tissue such as eyelid, and preorbital edema is thus a characteristic finding severe renal disease. And as we already talked earlier, brain edema or cerebral edema can be localized or generalized depending on the nature and extent of the pathologic process or injury. And the swollen brain exhibits narrowed sulci and distant gyri. And with pulmonary edema, the lungs are often 2 to 3 times their normal weight, and it will be fluid filled and will have somewhat like liver-like appearance. To summarize, edema is presence of increased fluid in the interstitial tissue space or in body cavities, and its formation is determined by hydrostatic pressure, oncotic pressure, vascular permeability, lymphatic channel blockage, and sodium and water retention. Thanks for watching. If you like this video, please give a thumbs up and subscribe for more. You can also check my other video about anemia too.